Here we're going to be looking at the information from Chapter 9 in Clinical Pharmacology, looking at drugs to treat inflammation, so the steroidal and non-steroidal anti-inflammatory. So along the way, we've kind of mentioned these, and the non-steroidal anti-inflammatories are probably, from a sports medicine standpoint, probably one of the more common drugs that you're going to see get utilized. So we'll kind of talk about, we're going to start the chapter by just reviewing the inflammatory process, which we've done multiple times by now, but just to kind of go through so that you're aware of those phases, so that you can kind of get a good understanding as to how both of these different types of medications affect the process of inflammation. So the inflammatory process, when we're looking at inflammation, so it's basically our body's response to cell injury. So when cells get damaged, and again, typically when we think of orthopedic injuries, it basically kind of kickstarts the process to kind of allowing the body to heal effectively. So basically, when we talk about like what are the goals of inflammation, we'll look at basically kind of cleaning out the area of debris and allowing that initial healing to start to occur. So we're essentially looking to kickstart the healing process with this. So this is probably, as I said at the beginning, one of the more common interventions that we look at in sports medicine when we look at corticosteroids and non-steroidal anti-inflammatory drugs. These are probably two of the more common things that typically will get recommended to our patients when dealing with their injuries. The key is knowing, again, how they should be kind of incorporated to make sure that we're kind of optimizing the healing process. So the inflammatory process, as we said, it's a physiologic response to injury. We have our classic signs. So we have those cardinal signs of inflammation: the redness, heat, pain, swelling. We'll include loss of function in that. We had discussed that in modalities. So those are kind of the classic signs, but again, just being aware of sort of the physiology that causes them. So again, I kind of want to emphasize that and kind of make note to yourself, because that'll kind of allow, again, some of the physiologic responses to that and how anti-inflammatories are incorporated into our process. So we know that one of the big events that occurs is that vasodilation and blood wall permeability, and a lot of that is going to contribute to a lot of the swelling and pain that occurs. That's also going to contribute to that, to the heat that kind of gets formed in the area, that along with a lot of the metabolic processes that are occurring. So the blood vessels will dilate, the endothelial walls become more permeable, which allows, which obviously we know we need to have, for instance, the white blood cells kind of move out from the circulation out to the extracellular space, but that's also going to cause fluid to escape, and that's going to contribute to a lot of the swelling, and then we know that swelling could also contribute to pain. So we have those vascular changes that come about as a result of cytokine release. And then we also kind of have your other chemical mediators that, as a result of the cells getting damaged, get kind of put out. The histamine, bradykinin, and prostaglandins being the most common. So they are going to basically be part of the substances that also cause that sensitization of the nerve endings. So that's going to be what causes some of that pain that occurs. Our nerve endings are very sensitive to a lot of these chemicals, and that's going to cause the increase in pain response. So the illustration here, so this just kind of shows, the inflammatory response and kind of how it's working. So if you kind of follow along this this little illustration here that's also in your book. So when we have that initial tissue damage, and they're simply just illustrating tissue damage with, someone's skin getting penetrated by a pin here, but you see you get that very rapid kind of response. And you get that local dilation and increased cellular capillary permeability that's going to occur, and you kind of have your three major phases. Now, we kind of talked about these phases and modalities. We might have used some different names for things, but again, it all kind of means the same thing. So the initial phase right after is what we would call the vascular phase. So if we kind of move over to this picture here, and I'll kind of highlight. So, and you read the description down there, chemical signals are going to cause increased vasodilation, and that's going to also increase the permeability of the vessels, okay? So that's going to contribute to a lot of the swelling and pain that occurs, just simply because now a lot of that extra fluid is going to come out, and that's going to cause that added swelling, which will put pressure on nerve endings and lead to swelling and pain. So again, we need that to occur. Again, the chemical mediators are going to cause that dilation of the blood vessels. It's also going to cause the endothelial cells to shrink, and that's going to allow the vessels to become more permeable. If we look at the cellular phase, so the cellular phase now, so you can see they're actually showing here the leukocytes kind of squeezing through the blood vessels and kind of migrating to the injury site. Okay, so you see where some of those chemical signals were released earlier, and now you also have the phagocytosis starting to occur. So within a few hours of the vascular changes, these what we call chemotactic mediators, which target leukocytes, which initially adhere to the endothelium. We talked about that process. They eventually will squeeze out and allow them to go to that site and be able to start to remove debris, and which would be the next stage, which we're going to talk about as we move over here. So neutrophils and macrophages arrive. You can see they start to eliminate the debris in the area and start to clean it up, and then that kind of is where you have, and this occurs usually within 6 hours, those macrophages will occur. Those macrophages are also going to secrete more pro-inflammatory cytokines. So you have other pro-inflammatory cytokines that are going to get released. You have the interleukin-1, interleukin-6, and tumor necrosis factor, some of those common ones that will get released during that time. And again, that's going to induce coagulation in the blood that occurs. It's still going to allow for increased vascular permeability and still promote that acute phase. But that kind of leads you into, so you can see this is kind of the last phase, which will then lead you into that what we talked about in the other classes, the other coursework, is we talked about then that leads into that proliferation phase where then like some of the scar tissue will start to form. But this kind of highlights the various events that we look at when we talk about inflammation. Now, that's the acute response. What we could eventually get into, so if there continues to be some type of repeated exposure to some type of offending element or injury process, you can end up with chronic inflammation. So when we look at chronic inflammation, what effectively is going to happen there is, again, from continued tissue damage, you get more accumulation of macrophages and other lymphocytes. You also get, more increased fibroblast activity in that area. So basically what you're getting in the state of chronic inflammation is you're getting that sort of continued cellular response. And what could happen, for instance, because of that, you get a added scar tissue to the area, which we know that we need scar tissue for healing. However, too much can cause like an area, particularly if we're looking at like a joint, for instance, you can get fibrosis at the joint. You could also get chronic inflammation, could also lead to what's called the formation of granulomas, which is a mass of cells that consists of basically like kind of like clumped together macrophages and other activated lymphocytes. So we don't want to get into that state of chronic inflammation. We want to obviously allow the healing process to kind of sort of continue and allow itself. So if you kind of get stuck in that inflammatory process, you never kind of truly get through into the healing and remodeling phases, which is what we look to do when our body's trying to heal from something. So the objective when we're not trying to, we always talk about inflammation and kind of how we handle it. Remember, we just want to control inflammation. So again, inflammation is a normal process when there's injury. We need to control it because what happens is we have kind of all of these secondary effects, okay, that produce issues. So all the pain, the swelling that occurs from it, we want to kind of keep that under control because particularly from the standpoint of an orthopedic injury, we want the person to be able to rehabilitate, move, and strengthen the area. So when we look at kind of how to manage this, we look at kind of our common examples of anti-inflammatory medications, and we'll kind of talk about, when an NSAID or when a corticosteroid is a little bit more appropriate. We've actually talked about some corticosteroids in regards to respiratory conditions, as we talked about earlier in the semester. So what we're effectively looking to do with both of these two categories of drugs that we're looking at here, we're basically looking to kind of relieve pain. So we know that there's a pain relief mechanism. There's also some of the swelling, so that we could kind of minimize how much of that forms. So we're basically looking to utilize pharmacologically these drugs to minimize some of those negative impacts of inflammation. However, we still have to make sure the inflammatory process can effectively take place because of the fact that we need that in order to have healing. So when we look at what, say for instance with NSAIDs, so NSAIDs look to kind of just inhibit and kind of limit the vascular phase of inflammation. Whereas when we look at corticosteroids, they kind of alter the overall immune response and are immunosuppressive. So they actually look to even kind of impact like the lymphocyte reaction that occurs. So anytime you're using any type of anti-inflammatory agent, the thing you have to remember is they don't basically address what caused the disease or the injury. They just basically are addressing the inflammatory process. So that's an important part to remember. So that's what we're basically looking at. And again, both of these will work, and we'll kind of talk about the different mechanisms by which they kind of alter the inflammatory process. So the anti-inflammatory medications function to inhibit various parts of what we call the arachidonic acid cascade. So the arachidonic acid cascade basically involves some enzymes that produce the inflammatory response. And we'll kind of discuss this. So NSAIDs act as both an anti-inflammatory and an analgesic. And what basically happens is NSAIDs look to target what we call the cyclooxygenase, which is a rate-limiting enzyme that produces prostaglandins. Now, that's in contrast to corticosteroids. So corticosteroids will actually look to, they flat out prevent arachidonic acid from basically getting released from the phospholipids, and they actually will reduce the synthesis of prostaglandins through that, amongst some other enzymes as well. So the corticosteroids actually work earlier in the process, so we'll kind of show this later on as to how both of these drugs kind of limit that whole inflammatory process. Corticosteroids, so again, corticosteroids, now these are endogenous hormones. So our body naturally does produce corticosteroids. These are also called glucocorticoids, or just some people will just refer to them as steroids. So there are naturally occurring glucocorticoids in our body that we've talked about. If you remember going back to our talk on the endocrine system, we had discussed many of those. So when we're talking about corticosteroids from the standpoint, from a pharmacological standpoint, they're a synthetic version. They're basically like a synthetic version of cortisol. Again, they're potent suppressors of inflammation. And as we had talked about, we kind of mentioned this along the way with some other chapters, but they're used in autoimmune diseases. And if you think about it, it would make sense that autoimmune diseases would be, it would be clinically indicated to use corticosteroids in the case of autoimmune diseases. Many of them, number one, involve an inflammatory process, but also they're used to suppress the immune system. So and that's actually one of kind of which it sounds kind of strange, but one of the sort of adverse effects is you do get a suppressed immune response. However, in the case of individuals that have autoimmune diseases, their immune system is kind of effectively overactive, if you will, anyway. So you want to make sure that in those cases you are actually looking to kind of suppress the immune system, and that's where corticosteroids get utilized in those circumstances. Now again, the potential complications when we look at corticosteroids, and this is why there's specific reasons why we would use corticosteroids versus NSAIDs, particularly in a sports medicine context. Again, they both, as we had talked about, both NSAIDs and corticosteroids relieve pain and inflammation. But however, there's some kind of added sort of complications when we look at corticosteroids, particularly when you're using them for a prolonged period of time. So when they get utilized for a prolonged period of time, there's potential issues as it relates to a lot of basically your body's kind of natural production of the hormones basically getting suppressed. So that's something to kind of be mindful of, is that you do get that suppression of your natural production, which is the case when we look at the idea of rapid withdrawal. So when typically, depending upon how long someone's been given a corticosteroid for, many times it's not like some other drugs where you'll just kind of stop taking them. Many times you have to do, again, depending on the dosage and how long they've been taking them for, they many times have to kind of be sort of weaned off of them and kind of have a gradual kind of wind down, if you will, of the actual dosage. So again, you have to make sure that you consider a lot of the risks and benefits, if you will, when you're kind of looking at administering the corticosteroid. So again, we know they're very potent drugs. They're very effective in as far as what they can do as far as the pain and inflammatory response. So make sure to kind of look at, again, as always, we refer to tables here. So some various examples of corticosteroids. So be familiar with a lot of the names. Here we're kind of mentioning three very common ones: cortisone, hydrocortisone, prednisone. Be familiar with the names. There's a couple others listed in that table as well. So in examining the therapeutic effect of corticosteroids, as we had talked about, we're here now referring to exogenous corticosteroid function and what that means to the body. So again, we know that our body naturally does have endogenous corticosteroids. So endogenous corticosteroids will also work to inhibit the inflammatory response and kind of suppress allergic disease by basically releasing histamine. So we do get that kind of natural response from the body as far as like the what we do endogenously. However, in again more extreme circumstances, we need that exogenous corticosteroid in order to do that. Now we have to be mindful of that. So the anti-inflammatory effects require basically those high levels of circulating corticosteroids. So that's what allows us to utilize them pharmacologically. So when we look at a lot of the medication differences, so when you look at the pharmacodynamics and pharmacokinetics of a typical corticosteroid, you have to note the dose and half-life. So table 9.2 in the textbook kind of gives a little bit of basically a typical corticosteroid. So they go over prednisone, which is one of the more common ones, kind of goes through that. There's also different rates of sodium retention that you have to be mindful of as well. So basically, when you're looking at the differences among the corticosteroids, you basically look at, like, as far as potency, the half-life, and how much fluid retention can occur. Those are kind of like the differences between all of them. So a lot of the different corticosteroids will have different effects on those, and that obviously impacts dosing and how long you would take them for. Now, we kind of discussed this a little bit earlier, but obviously what our concern and some of the issues with administering corticosteroids is that obviously it's going to impact our body's ability to kind of naturally release hormones, because basically if you're getting exogenous doses, the body basically realizes it doesn't have to really do its natural release. So large doses of corticosteroids for prolonged periods of time will inhibit the release of adrenocorticotropic hormone from the pituitary gland. And if you remember this from the endocrine system, that particular hormone is what releases, for instance, cortisol from the adrenal cortex. So that's going to be inhibited. So again, that HPA axis, or the hypothalamic pituitary adrenal axis, could be suppressed. If it's suppressed for long periods of times, that could again create issues, and this is part of the reason why we have to be very careful with how long they get administered for, and also how a person comes off of them. So again, normally ACTH is what helps to stimulate cortisol release in the body. If for some reason that, again, obviously as the body's getting exogenous corticosteroids, that process gets limited a little bit. Now, when we start to talk about, again, a very common sort of administration technique is a cortisone injection. So when you have local administration, you don't have as much of that systemic response, okay? So local administration of corticosteroids, as we talk about with injection, there you get a high concentration without a lot of the systemic absorption, so you don't have as much of an effect with that. You could even kind of say the same with the inhaled version of corticosteroids that you utilize, like for allergies. It's kind of a similar idea, is that if you administer it locally and not systemically, you don't have as much of a concern. There's always the potential for some of it to get absorbed systemically, but it's definitely not as much as you would when you're taking the drug systemically. So this is kind of just demonstrating, this is an illustration in your book, just kind of showing you the relationship, and we discuss this in the pathology portion of the text, the relationship between the endocrine glands. So this is the normal hypothalamic pituitary adrenal axis, that when the person is under a stress response, that helps in kind of releasing cortisol. So this is just that natural response. So again, understanding the hormones and how they get released and where they get released from. So you have, corticotrophic releasing hormone, adrenocorticotrophic hormone, and then you have cortisol basically getting released into the periphery to have its peripheral effects. And this is just kind of showing that relationship. Again, what you have to be mindful of is anytime a corticosteroid is given, that this potentially can get disrupted from the standpoint of, again, the body's not going to look to produce that endogenous cortisol quite like it would if there's exogenous cortisol, or if there's exogenous cortisone basically getting delivered to the body. So in looking at how the mechanisms and how corticosteroids are going to operate, so again, remember there's kind of two actions that you're going to be looking at with corticosteroids. So, before we get into like the cellular issues and things like that with leukocytes, you look at both an anti-inflammatory and immunosuppressive. So again, they function to decrease inflammation by suppressing the migration of leukocytes and basically reversing capillary membrane permeability. So with the administration of these, you're going to have less leukocyte migration, and you're going to be reversing the capillary permeability, which again, that's going to influence some of those things that we experience. For instance, reversing the capillary membrane permeability is going to use to help bring down some of the swelling. So some other mechanisms that we look at involving that are important. So it's going to inhibit other factors of the inflammatory response. There's other chemical mediators that are going to be suppressed with this. Decrease vasoactive factors and decrease fibroblast activity at the site. So you're also going to be reducing the ability of some of the healing factors, if you will, but again, we're doing this in relationship to kind of lower some of those negative effects of inflammation. Diminish lipolytic and proteolytic enzymes. So again, those are, again, other chemicals that are responsible for a lot of the effects that go on during the inflammation phase, and it's going to suppress vascular changes responsible for inflammation. So basically, when you're looking at corticosteroids as a whole, you're effectively looking at again, reduction in the synthesis of a lot of the inflammatory mediators, okay? So even things like prostaglandins are obviously going to be inhibited as well. So, and it's a greater inhibition. So one of the things you'll see the difference between corticosteroids and NSAIDs is that corticosteroids basically interfere or basically create a stop in the inflammatory process earlier on in the process, which has a much greater effect on the process of inflammation. So this is part of the reason why we only really use corticosteroids in what would be considered a little bit more extreme cases. That's why you typically see people, if they're just trying to have like a general reduction in the effects from inflammation, they're going to tend to use NSAIDs. They're going to tend to use the non-steroidal anti-inflammatories because you're not looking to always bring this down quite as much, okay? So again, the other thing you'll get with this, with the massive amount of, particularly with the leukocyte function, so given the fact that they have a much greater inhibitory effect on the white blood cells, that's also why, that's also part of what contributes to the immunosuppressant effects of the corticosteroids. So even somebody who's on a corticosteroid, not for an autoimmune disease, they are a little bit more susceptible to infections because of the fact their immune system is basically getting suppressed. So when we look at the routes of administration, there are various routes of administration when we're talking about corticosteroids. So corticosteroids could be administered in a lot of different types of modes, basically. So, they could be given intravenously, they could be given orally, they could be given intra-articularly. Most people are familiar with corticosteroid injections into joints. They could be administered topically, or they could be administered intralesionally. They could be actually injected into a lesion, or transcutaneously. So, again, when we're talking oral corticosteroids, so usually their duration of action is around 12 to 36 hours. So the most common one probably for that is prednisone, is probably one of the more common ones, whereas some of the other ones have a little bit of a longer duration of action. So things like dexamethasone, betamethasone, they can last a little bit longer. Again, prednisone is very commonly used because it's very inexpensive. It's available in oral form. So that it's pretty much a go-to many times if we're looking for that sort of suppression of the inflammatory process. They should always be administered with food because they can cause some GI upset. So that's an important thing to note. Again, sometimes some corticosteroids are formulated in a way that extends their duration of action. So some preparations of like methylprednisolone can have a longer duration of action. So and that's usually going to be utilized when you're talking about like injections. So some of your other ways that are very commonly administered, so you can have nasal sprays, which are typically very common in a lot of allergy medications. Again, you reduce the risk. So when you're doing like again, as we talked about before, when you do some of these local administrations of some of these corticosteroids, you lessen the chance of the systemic negative effects that you get with oral. With the oral effects, because it's absorbed a little bit more throughout the system, there's a little bit more risk with that. And we had talked about, again, intra-articular injection, the duration of action does tend to be a little bit longer, so anywhere from 1 to 4 weeks. So looking at dosing guidelines, again, it's going to be very variable depending upon what the patient's basically getting treated for. So it really depends on the treatment and the response of the patient. So again, the idea is corticosteroids will mimic the cortisol surge during stress. So if by chance somebody is being treated with corticosteroids, they may actually even get extra doses during times of acute stress, just so that you're basically mimicking the body. Because again, many times as a person's getting these corticosteroids, their body's not going to produce quite as much. So if they're on a long-term prescription of it, they may get told to take a little bit extra during times of stress. So again, another thing, as we had kind of already talked about, if therapy lasts longer than 7 days, you're going to have to require a taper to kind of discontinue it. So again, just some options there. So standard formulations here. So methylprednisolone is one. So again, typically someone will be giving 4 milligrams of methylprednisolone over 21 days. So that's typically what you'll see. And that's used many times to treat a lot of times like some, conditions in sports medicine. I think like, many times like if someone's having low back pain, this might be something or some way that this might get administered. But typically, anytime have therapy that lasts longer than 7 days, you're going to have some type of taper, because otherwise you could end up with an adrenal crisis, because of the fact the body has to know that it has to get back to producing its own cortisol. So that's something to keep in mind. So, and that may be something you have to talk to a patient about, like make sure to reinforce that with your patients. Hopefully the physician does as well, and it's kind of in their pharmacy packet that they get. So higher long-term doses, there's some other things to be aware of. So avascular necrosis of the femur or humerus, we're not really sure as to why that occurs. The reason, like I said, we're not sure, but it can possibly increase lipid levels, which could reduce blood flow. So there is the belief that there's just decreased blood flow to the area, and that could be part of the reason for the avascular necrosis. And this is kind of an important to consider when treating certain conditions. So just make sure you're considering that in your patient education, that there could be some certain conditions where you want to make sure to kind of monitor some of the dosage and how long they're on something for. For the most part, most of the short durations of times in, particularly when you talk about sports medicine settings, the short duration that most individuals will be on from the standpoint of an anti-inflammatory effect, you don't tend to get a lot of negative effects from that. It's only really when you start to look at like long duration therapy with this that does get to be a little bit more of a concern for a lot of the negative effects. So again, so take a look at, table 9.2 kind of gives a really good summary. It does kind of talk about, some of the, particularly the negative effects. So again, the immunosuppression aspect is something to be mindful of. And again, just the musculoskeletal adverse effects. They do talk in general too that some just general arthralgia could come about as a result of treatment for this. There is also the risk of like tendon rupture and some other issues that could kind of come out with this. So again, make sure to kind of look at all those different effects and make note of them in addition to what we talked about here. Now, as far as indications and precautions, again, multiple conditions in sports medicine. So, there's a number of orthopedic conditions that commonly get treated with corticosteroids. So everything from bursitis to different types of osteoarthritis, even some other types. When you talk about like rheumatoid arthritis, even in case there's some cases where if there's rheumatic diseases can also be treated with this. So whether it's orthopedic or even if they have some type, if an athlete were to have some type of autoimmune disease, there's application there. Now, the one big thing as far as a precaution, and this could always be a concern for an active individual, is the immunosuppression that occurs, which leaves you vulnerable to infections. And then, not only does it leave you vulnerable to infections, but potentially more severe forms of the infections. So they even talk about in the textbook how people with chickenpox or measles, they might, people might have more severe reactions if they're taking corticosteroids. So, be aware of some of the other precautions. There's a little in the pharmacology sidebar, they talk about some of the different precautions that are available there. The other concern is that if you have high levels of exogenous, and this is something we've talked about already, but high levels of exogenous corticosteroids over a prolonged period of time could basically cause a decrease in the amount of cortisol that is secreted naturally in the body. So basically, someone who suddenly stops, if they're on higher doses for a long period of time and they were to suddenly stop taking it, they could basically get like an acute adrenal insufficiency, which, to put it in perspective, basically creates like what you get, like that's basically Addison's disease, where the person is not secreting cortisol, which can create a bunch of different effects from that. So again, know the signs and symptoms of adrenal insufficiency. So things like, irritability, nausea, joint pain, dizziness, low blood pressure, those would be all things that would come about. And again, basically the way you avoid that is by, if somebody is on a higher dose of a corticosteroid, that they taper off of it over the course of several days or weeks to make sure that the adrenal cortex could resume its normal functioning and could produce the appropriate amounts of cortisol. So some other deeper looks at some adverse effects. So there's a point in the text, they talk about pregnancy. So when you talk about musculoskeletal inflammation late in pregnancy, corticosteroids are preferred for pregnant women. It is particularly during the third trimester, because non-steroidal anti-inflammatory drugs are contraindicated in the third semester. However, there's potential issues that could come about with corticosteroid use. So, corticosteroid use, some of the risks during pregnancy include preeclampsia, low birth rate, preterm birth, potential hyperglycemia and ketoacidosis, particularly if the patient has gestational diabetes. So again, that'll kind of be looked at as far as some of that. So, and the other thing is, sometimes if a woman has an autoimmune disorder and she's pregnant, they may have to consider using corticosteroids, because some of the other medications that can be utilized can be harmful to the health of the baby. And that's why they would tend to use that. So again, it's going to be, they're going to kind of look at, pardon me, what they would use during pregnancy. But again, there's still other potential risks even during pregnancy with the corticosteroids. We talked about one of the big things, we've mentioned this over and over again, prolonged HPA axis suppression can have ramifications. So again, the concern there is that if there's been prolonged usage of corticosteroids, to make sure that there's appropriate tapering in those instances. So typically what they look at, so if an adult patient is receiving more than 20 milligrams per day of prednisone or some type of equivalent, that's where you're really susceptible to this. So again, this isn't for people that are on short-term dosages. Again, most individuals in sports medicine, when they're taking these, when they're taking corticosteroids, it's for short periods of time. Usually that doesn't require a taper, and there doesn't tend to be a whole lot of negative effects from them. Where this gets to be a bigger concern is in situations where it just has to be, given for a prolonged period of time. And again, some common side effects. This is just a partial list of some of the more common ones. I would encourage you to kind of look at some of the other ones that are in the textbook. So agitation or irritability, increased blood sugar, cholesterol, and triglycerides, because it certainly could do some things with your blood lab results, sleepiness or tiredness, weight gain, because many times you get some fluid retention with it, and that's going to be where the weight gain comes from. Long-term use can also lead to abnormally high levels of cortisol. So, Cushing syndrome or hypercortisolism is something that could happen as well. And you remember some of the signs and symptoms for that, as we talked about in pathology class. So now we look at non-steroidal anti-inflammatory drugs. So these are probably some of the most commonly used drugs, and particularly in sports medicine and orthopedics, you will have this. There are many different types of NSAIDs, and aspirin would be included in this, because aspirin has all those same similar effects that we have here. So the function of non-steroidal anti-inflammatory drugs, they are an analgesic, so they help with pain reduction. They're anti-inflammatory, antipyretic, which means they can reduce fever, and they're also antithrombotic. So they also have, your antithrombotic effects, particularly the traditional non-selective NSAIDs. So, and we'll talk about the difference between the traditional non-selective NSAIDs versus, say like the cyclooxygenase 2 inhibitors, which are a little bit different. So the idea is they inhibit cyclooxygenase. So if we're looking at this illustration that I have here, so your corticosteroids work all the way up here. So corticosteroids work at the level of kind of phospholipid development where they kind of limit everything beneath this. Basically, when you look at your non-steroidal anti-inflammatory drugs, they're working down in here. So they limit it at the cyclooxygenase level, and you see the difference between cyclooxygenase 1 or COX-1 and cyclooxygenase 2. So cyclooxygenase 1 is kind of the enzyme that kind of looks at overall protection. So kind of like your general body functions. They protect the gastric mucosa. They affect platelet aggregation. Cyclooxygenase 2 deals more specifically with inflammation. Now, when you take a non-selective kind of traditional NSAID, they kind of inhibit both. So that's where some of the sort of the negative effects that we get, some people that complain of issues with their GI tract with these, that's where they come from. So the selective or newer cyclooxygenase 2 inhibitors, they basically, you have specifically a decrease with the GI toxicity because they don't impact this, okay? So the cyclooxygenase 2 inhibitors, which we'll talk about a little bit, they kind of only affect this, whereas all of your more traditional NSAIDs basically eliminate that process at the level there where arachidonic acid breaks down into the COX-1 and COX-2 enzymes. So looking at the various therapeutic effects, just kind of going back a little bit, and you can make note of this wherever you want, but another thing to note, some of the selective cyclooxygenase 2 medications have actually been withdrawn from the market. So, your book talks about them. Vioxx and Bextra have been withdrawn because of there was seemingly a risk of cardiovascular events. So as of right now, the only selective COX-2 inhibitor that is available is Celebrex or celecoxib because of that. So that's currently the only one available for use in the United States. It does still have that similar risk, so that is just kind of something to make note of. So we look further at the therapeutic effects. So again, the primary role of NSAIDs is to relieve that musculoskeletal pain and inflammation. So again, there's a lot of different options available there. They're less effective than opioids, but again, they have fewer adverse effects. So they don't have as strong of a pain relieving effect as opioids. So if you do need a stronger pain relief, you can possibly co-administer both an NSAID and an opioid, and then just kind of reduce the opioid dose as needed. So that's something that you would want to, look at and consider with as far as, managing the overall condition. And again, you would want to look. So like, for instance, ibuprofen could be prescribed in combination with hydrocodone. So that would be like one example that you would particularly look at. So again, you kind of get the benefits of both there. You would get they would help with that sensation of pain. However, and then in addition to that, you would have that reduction in inflammation. But again, the idea would be to gradually start to reduce the opioid dose over time. So that would be something to keep in mind when you're looking to do that. Non-musculoskeletal examples. So again, menstrual pain is the only hollow visceral pain or the hollow organ pain that would be utilized for that. So that would be one situation. It is pretty effective at menstrual pain when women are going through their menstrual cycle. NSAIDs can be used plus an antiemetic in treating migraine headaches. So those with severe migraine headaches, and they could combine the treatments there. And ketorolac can produce analgesia equivalent to morphine to treat diabetic neuralgia. So ketorolac or Toradol, 60 milligrams administered intramuscularly can actually produce the analgesic equivalent of that. So that could be something that you can look at with that. They do talk about, they do say that generally there's a lack of efficacy in general neuropathic pain, but you can get some benefit with that particular medication as it relates to diabetic neuralgia. So looking at the mechanism of action, we kind of got into this a little bit earlier. So, and you can, there's a similar picture in your textbook to the one I showed. I just showed a different one because I had access to it. So the mechanism of action, so again, the classic COX inhibitors aren't selective. So they inhibit all types of cyclooxygenase activity. So they basically impair the transformation of arachidonic acid to prostaglandins, prostacyclin, and thromboxanes. So that kind of limits it. Now, again, the issue with that is like cyclooxygenase 1, I didn't use this term before, but it's kind of like the housekeeping enzyme for a lot of general body processes. So that's where some of those potential adverse effects, particularly gastrointestinal toxicity, if you will, can become a problem. So again, NSAIDs are going to inhibit prostaglandin and thromboxane synthesis. So again, it could affect pain in three ways. So again, prostaglandins reduce activation at nociceptor neurons. So reducing the prostaglandins can decrease that. They decrease the recruitment of leukocytes. So again, kind of impairing that aspect of the inflammatory process, which then, if you're reducing the recruitment of leukocytes, you're thereby the production of a lot of those leukocyte-derived inflammatory mediators are also going to decrease. NSAIDs in the brain also prevent prostaglandins, which cause pain. So NSAIDs that cross the blood-brain barrier can prevent those prostaglandins that act as pain-producing neuromodulators in the spinal cord dorsal horn. So these are all the different ways that pain could effectively be kind of diminished as a result of utilizing NSAIDs. So looking at routes of administration, so there's various routes of administration for NSAIDs. Again, oral is going to be the primary route, particularly when you're looking at, over-the-counter NSAIDs, obviously, but even prescription strength dosages. Typically, oral is going to be the most common route. And that's usually what's going to be given initially with musculoskeletal inflammation, whether that's from things like arthritis and so on and so forth, some of those orthopedic conditions. Some particular ones, so one of the more common injectable types, I mentioned this early, ketorolac or Toradol, that's the only, is really the only NSAID that's routinely administered via a parenteral route. There's some other forms that will come in gel form, so diclofenac, ketoprofen, piroxicam gel are sometimes used. They can be used topically. So for these particular types are used in topical form. So it's a gel. It is a similar efficacy as the oral with fewer gastrointestinal side effects because it's not having to be absorbed through the GI tract. Again, now here there's something different you'd have to just take into consideration is that skin irritation, obviously with a gel delivery. So just as an example, so like for hand and knee osteoarthritis, you're basically going to use this for for greater than or maybe even up to 6 weeks. Can be very effective. So those are some things to kind of look at. Obviously, again, you have to be concerned about, again, the cyclooxygenase 1 enzyme is responsible for protecting the stomach lining. So that's something to keep in mind when you're administering an oral NSAID that, over time you could start to develop some GI side effects. So now again, although topical and oral NSAIDs produce similar efficacy, patients who typically will use a topical NSAID report fewer GI effects, which that should make sense because of the fact that you're basically using a more local application of it. Again, the cardiovascular and renal safety profile of topical NSAIDs, they're still kind of looking at that to see, again, the superficial rashes is probably the most common thing that you're going to experience as far as an adverse effect with the topicals. So in looking at the pharmacokinetics of NSAIDs, probably some of the biggest differences you're going to have between all the different types of NSAIDs are their half-lives and safety profiles. So those are some things. In general, they're systemic drugs that are distributed pretty well throughout the body, and they penetrate synovial joints well. So they're obviously ideal, as we had talked about, for treating musculoskeletal inflammation. They reach peak plasma concentration in about 2 to 3 hours. Some of this, again, food and antacids can delay absorption. Now, you're still typically, most people are going to have it recommended to them to take food because of the potential gastrointestinal upset that can occur if taken on an empty stomach. So it's just kind of a give and take there, but you just have to know that it's just going to delay the absorption and kind of just affect the onset. But it still gets absorbed fairly well. As far as distribution, they bind to plasma proteins, and most of the NSAIDs are extensively bound to plasma proteins, usually albumin, and they achieve good concentration to have that CNS effect. So there is a certain concentration in order for them to have kind of that central analgesic effect for pain relief that does occur. And it's important to note, again, as we talked about, they're going to be widely distributed, so they'll penetrate the synovial joints. And, typically you'll be yielding synovial fluid concentrations in the range of half of the plasma concentration. So that's going to allow for them to, to have that effect and reduce inflammation at the joints. As far as metabolism, they do have a first pass effect at the liver, which could reduce some of the bioavailability. Again, that'll factor into the dosing that occurs. So your steady state for ibuprofen or diclofenac is 1 to 4 hours. That's just one example, kind of looking at those two particular types of drugs. And then the excretion is going to be primarily renal excretion. So obviously that's how then it's going to be eliminated with that. So one of the things you have to look at is any type of kidney or liver disease. The NSAIDs are going to be a contraindication because of the fact the liver, there has to be that first pass effect at the liver, and then in order for the elimination, you need to make sure that it can be eliminated through the renal system. So any type of hepatic or renal disease, because there could be definitely potential altered pharmacokinetic effects that can create a much more severe health condition with the individual. So looking at some other precautions and adverse effects. So again, there could be adverse effects kind of in various systems. We already kind of mentioned some of the things with gastrointestinal side effects. So that's probably the most common thing that people experience is GI toxicity. So again, basically from taking an NSAID, there's just a little bit of a greater risk to the mucosal barrier, just because again that cyclooxygenase enzyme is responsible for basically protecting that. So that inhibition of the prostaglandin synthesis could basically weaken the stomach lining and put them at risk for bleeding. And then some of the other common symptoms that a lot of the upper gastrointestinal symptoms people will experience. So, the indigestion, gastroesophageal reflux are some things that people would experience. Even just general nausea is not uncommon. You can experience some lower GI stuff. Some patients do report, getting diarrhea from taking NSAIDs. And you go as far as possible ulcer development. So that is something to keep in mind, that you do sometimes get, there have been people who've gotten ulcers from the mucosal damage. Many times they'll co-administer a proton pump inhibitor or an H2 agonist just to help reduce some of the negative effects associated with that. General cardiovascular things do have to be considered. There have been cardiovascular events with several NSAIDs, so you do have to keep in mind with that. So if there are cardiovascular comorbidities, you do have to be aware that it could exacerbate that. We'd already mentioned renal contraindications. So nephrotoxicity is an adverse effect that could happen in general with individuals. People who already have existing kidney disease will likely not be utilizing an NSAID. But even individuals that don't, there's always the risk of possible acute damage to the kidneys. So that's important to keep in mind. So there are various dose-dependent renal side effects that can occur. They're uncommon at doses recommended by manufacturers. So compared with gastrointestinal and cardiovascular, the renal complications aren't as common. Because the drugs are cleared by the kidneys, renal damage does result in kind of more toxic serum concentration. So that's kind of part of the thing, is that the kidneys are needed to clear the drug. So basically, if the drug can't get cleared because the kidneys are damaged, you basically end up developing higher concentrations of the drug, which could produce problems. There's also the potential for like electrolyte imbalances, so like hyperkalemia could form, and again, some of that is occurring due to the physiology at the kidneys as well. So that's something that could potentially develop in an individual, can come up with severe electrolyte imbalances, which can promote and cause other particular conditions. So there's various reasons to be concerned with this. So if someone is elderly, that could put them at risk for this. Obviously, if they're elderly and they have a kidney disease, that would pretty much limit what they have. They also do think that genetics might have an influence of the NSAIDs on kidney function and kidney disease, so that's something to be mindful of. As well. But again, as long as you're not taking like super therapeutic dosages and you're only taking it for a short amount of time, it's rare to have renal complications with that. Some other drug-drug interactions and some things that could cause contraindications. If someone has an allergy to aspirin, or they have aspirin intolerance, some people have an aspirin-sensitive asthma, which can occur. So people can develop hypersensitivity reactions, so they can get that, vasomotor rhinitis, the urticaria, bronchial asthma, and that's just due to the irreversible inhibition of the cyclooxygenase enzymes. You also have to be aware of any type of concurrent anticoagulant use that could cause bleeding. So both NSAIDs and aspirin. So aspirin basically is basically your prototypical NSAID. Both of them can create bleeding issues, particularly if you're taking a concurrent anticoagulant with them. So in summary, again, so your anti-inflammatory medications have very particular effects, and again, they do inhibit prostaglandin protection. So something to be mindful of when you're looking at this is looking at what the anti-inflammatories do even beyond their therapeutic effects. Your potential adverse reactions, particularly when you look at the kidneys and some of the issues with the cardiovascular system. Again, corticosteroids are superior, but they come with further risks, particularly when you're taking them systemically throughout the body. Again, NSAIDs are going to be responsible for helping to reduce chronic and acute inflammation. And again, the effects are going to be the therapeutic and adverse effects are going to be secondary to the cyclooxygenase enzyme inhibition. Another thing to be aware of is just looking at aspirin. So aspirin is your prototypical salicylate, and that's again another analgesic, antipyretic, and anti-inflammatory agent. So look at in addition to ibuprofen, look at what aspirin is as far as its duration of action. So look at table 9.4 in your book. They also talk about kind of like the typical dosing for aspirin, so make sure to just make note of that as well when you're looking at aspirin and how it gets used. Also with aspirin, you have to be concerned about the risk of what's called Reye's syndrome, which is a rapid degeneration of the liver and causes brain damage. So kind of look at Reye syndrome as well, and this is part of the reason why we don't give aspirin to young children as an antipyretic, because the risk for Reye syndrome increases with them. And these are your learning objectives.